Hi, good afternoon. My name is Ashwati Matthews. I am an Indian doctor currently working as a cardiology research fellow in Memorial Health System, Ohio. Today we will be discussing two very interesting topics. The first one is from biostats and second is from cardiology. Uh, as you know, biostat is something really important when it comes to STEP exams. And before diving into our sessions, I'll just share my screen so we'll get a better idea about what I'm trying to convey. Hypothesis testing is something that really needs logical attention, and it's something which I found really interesting. So, before diving into the topic, I'll just give an idea of what hypothesis really means. Suppose I am doing a research on a particular drug AX. I want to introduce this drug into a large population. So, before introducing this drug into a larger population, I will have to test this into a small group of population, like 10 people. I'm trying to give this drug and I'm trying to see the results. And I got a result like 5 people are getting really good benefits from taking the drug. So I can't just say the drug really works because people will start asking, why can't it be just coincidence or why can't it be just chance? So to prove the drug and the result was not just chance, we use a p value. P-value means it's a statistical significance value. A p-value of less than 0.05 or 5% shows that the result I got from giving the drug X is only based on chance 5%. So that shows 95% the drug is working. In that case, we take two types of hypothesis. The null hypothesis, which really means the drug has no relation with the result. The alternate hypothesis means the drug really works for this disease. So we'll have to reject the null hypothesis to come to this alternate hypothesis. So that is where the hypothesis really comes into action. And we also categorize the data we get from the research on like different forms based on which test we are using. Suppose we are comparing the results of two hypertension values, like two BP set of values in men and female, and we have to compare them. We use the independent t-test. It actually compares two set of values. If you are having a third set of value, or if you are having more than two sets of values, you will have to use ANOVA test. Got it? Okay. Now, if you are comparing categorical values, or if you have to compare different categories, like if you have to compare smokers and non-smokers and their association with coronary artery disease, or if you have to compare cholesterol, like elevated cholesterol and normal cholesterol levels in people with CAD, or if you have to compare diabetic and non-diabetic in CKD, there are two categorical values and you are trying to compare them. In such case, you use chi-square test. Got it? So to remember that, I use a mnemonic like C for chi-square and C for categorical. C. Okay. Then there comes a paired t-test. Suppose we are considering people who are taking anti-glycemic, drugs for their cholesterol value, suppose. And we are considering the values before taking the drug and after taking the drug. Now we are comparing the results, and for that we use a paired t-test. Okay. Then there comes the few tips, like the t-test is for two groups, T for two, so two groups. Categorical for what we use is chi-square test. If you are having a small group, we don't actually go for chi-square. We just use the Fisher's exact test. So that is one of the common mistakes which I have seen so far. And the statistical significant doesn't always means it's clinically significant. It's actually two different things. Okay, now we are doing a question here. The question says a trial compares mean systolic BP between three antihypertensive drugs, three groups. Which test is best? So for considering three groups, we will have independent t-test. So where will we use independent t-test? When we are taking two groups, here we have three groups, so we cannot go for that option A. Then there comes paired t-test. Where will we use paired t-test? When it's about the same groups before and after effect. It's not like that. It's about like three different groups. Option C is ANOVA. Option D is chi-square. It's about chi-square is related to categorical values. This is not categorical, this is quantitative values. So we go with option C, ANOVA. ANOVA because it's three or more independent means of which we are taking into consideration. So in that case, we go with ANOVA. So the summary is hypothesis testing really helps to identify the research result which we found really works or not. The different types of different methods we use to analyze actually help us to compare the data we get in different situations. So that and analyzing which test to use in which situation is something that's very important. As we have very few time, I'm not doing much questions. So that's about it. So next topic we are gonna deal with is ischemic heart disease. Ischemic heart disease is something which we are gonna see very frequently in our emergency departments. Suppose a 55-year-old man comes to our emergency department with chest pain for the past 2 hours. First thing that comes to our mind is taking the EKG. And EKG really helps us to differentiate whether it's a STEMI or whether it's an NSTEMI or a angina, or sometimes it can be a GERD too. So in such situations, we will have to respond according to the symptoms and the EKG findings and the troponin levels and all. So this is a basic scenario where we'll have to deal with a patient with chest pain. So diving into our session, I will just share the screen so you'll get a see about what I'm trying to convey. And here it comes, the ischemic heart disease. The core mechanism behind ischemic heart disease is imbalance between myocardial oxygen supply and blood flow. Suppose our blood vessels are really working and there is atherosclerosis or fatty deposits in these blood vessels, and the size or the lumen of the blood vessels really shrinks and it really becomes short, so that the blood that has to go through this will have to work under more pressure. So the blood that reaches the heart is having an imbalance with the oxygen demands and the supply. The demand supply mismatch leads to ischemia. The most common cause of this ischemia is the atherosclerotic plaques. This fat depositions or the narrowing of these vessels or the narrowed lumen really affects the most important cause of this concern. So what we'll have to do, like in some situations like Prince metal angina and all, vasospasm can cause the same narrowing of the vessels. In such situations, we act different. But in conditions that's associated with atherosclerosis or CAD, we'll have to take immediate actions. Like if you take action in a, like time is something very important here. Time is a deal breaker here. If we see a patient in 2 hours of the starting of chest pain, we will have more options to do. If the patient is seen after 24 hours, the number of options left behind is actually a lot limited. So dealing with a spectrum of ischemic heart diseases, the first thing you will get to see is chest pain, which is actually a basic symptom. From that symptom, you will have to come to a diagnosis and a treatment point. Suppose you are having a stable angina. A patient is having chest pain, but not always. He's having chest pain whenever he's on doing a work, whenever he's climbing stairs. It means that clot is there itself. It's not moving. It's a stable angina. In certain situations, the patient is having pain even at rest. So that's an unstable angina. The clot is actually moving. In certain say cases, when the patient presents, the EKG shows ST depressions, not elevations. So that's actually NSTEMI, non-ST elevated MI. In STEMI, there will be ST elevations. So these are the different aspects or the different ideas of this types of like IHD. And how this actually progress? This can progress very badly from a STEMI to a cardiac death. So timely interventions really matters. And the progression basically depends upon how occluded the vessel is. If the vessel is really badly occluded, the progression to a bad prognosis can really be fastened. So this is what I have already discussed about. A stable angina is something that's a fixed narrowing. So it doesn't actually aggravate with rest or anything. It's just aggravated with some work and all, and there won't be any significant EKG findings too. And the alarm things that we takes into consideration, or the STEMI or NSTEMI, will have troponin elevations. So that's a basic thing that differentiates an angina from a STEMI. Like the troponin or cardiac enzymes will be really elevated when it comes to an STEMI or STEMI, because there is actually muscle breakdown. The cardiac muscles are really broken down. The muscle breakdown leads to increase of cardiac enzymes, or the troponin elevations really signifies or shows, okay, the decreased demand or the decreased supply of oxygen supply to the heart led to the ischemia of cardiac muscles. So the cardiac enzymes have been released. That really shows an alarm situation. In certain cases, there is one extra thing that's called as silent ischemia that comes in diabetic patients who are taking who are already been on medication. So that's actually one of the reasons we consider diabetes as a like an angina equivalent. So, when we consider the etiology, whenever there is an endothelial injury, or whenever the body is having a high levels of LDL or high total cholesterol, this LDL just infiltrates into the vessel walls. And inside the vessel wall, there will be endothelial proliferation and fatty cell or fatty streak formation. These fatty streaks will lead to plaque development. The plaque development actually leads to narrowing of the vessels. The vessel which actually needs this much lumen would now shrink to a very small lumen like this. So that is actually a very like a restricted area for the blood to flow. In such situations, the plaque actually ruptures and there will be occlusion, which leads to complete closure of this vessel. So what happens? Blood don't flow outside. In such situations, uh, there will be like oxygen supply demand at the other side of the vessel. So that happens when there comes a ischemia. Here we can discuss a question. A 58-year-old man has chest pain and with an ECG findings of ST depression in 2, 3, and AVF. And he also has troponin elevated. What is the mechanism? So, just coming into the idea, like ST depression really shows it's an NSTEMI. Cardiac troponin is elevated, shows there is a muscular, like the cardiac ischemia there. And 2, 3 AVF, it really shows that there is something really significant happening. So, we have the options fixed obstruction. No, fixed obstruction, there would have been a ST elevation and an STEMI. It's not vasospasm, complete occlusion, plaque rupture with partial thrombus. Yes, it could be a plaque rupture with partial thrombus because it's an NSTEMI. So, according to each of these conditions, our treatment modality actually changes. Actually, vasospasm occurs in situations where that actually don't always goes to a very high profile management techniques, which actually in cocaine users, there is actually vasospasm associated chest pain. So vasospasm is something which we have to rule out before taking into consideration like the other diagnosis. ISD is basically oxygen supply demand mismatch that happened due to the atherosclerosis. So we will have to deal with different types of ECGs. I have taken a lot of ECGs to share with because due to the time constrictions, I'm not sharing them now. Like it's interesting to learn about ECGs and uh, like discussing about the different diseases like the 2-3 AVF is comes to associated with which artery. Okay, this artery starts from, it's a branch of which artery. Okay, like the AVL to one AVL. associated with which leads. So it's something very interesting. So I hope by the next session we can deal with different types of EKGs, different types of the like IHD management plans, and different types of like the investigation modalities that's needed to. So that's about it. Bye. Thank you. Hope this really was really helpful, and hope to find you in the next class session. Bye.